Yes, sir. We are live.
Yeah, thank you, Sandeep. Good evening, friends. Welcome to Indian Arthroscopy webinar. This webinar was most sought of because I think a lot of our sports medicine surgeons and arthroscopy surgeons were asking how to read MRI and how to have a good clinical correlation between arthroscopy findings and clinical findings and MRI findings. And I think Aditya, Daftary, and Sajeer Usman both are quite well into this topic of musculoskeletal radiology. And I think these are the best guys who can help us in solving the mystery of an MRI and making us understand how to read an MRI ourselves and then correlate it with some arthroscopic and clinical findings which we commonly see in our practice. We have our friend Dr. Samanta joining in from Calcutta, Secretary of Indian Arthroscopy Society. Welcome, Samanta. Some words and then we can start.
Welcoming everybody. Yeah.
Perfect. Amol and Tirath have also joined in on panel. So I think all yours, Aditya and Sajeer, you can run the show the way you want it to be. It's a basic learning arthroscopy course. People would be asking questions probably in between as well and stop you in between if you don't mind. And we go forward from here.
Okay, great. So I'm going to just like everybody get started. I hope everyone is well. This is going to be relatively, we're going to try and keep this simple from the standpoint of we are going to talk about how, so the way this session is going to go, we will start about how I read an MRI. So I'll show you what I do while reading it. That'll be about 10 minutes. Then we will start talking about some of the common abnormalities we see as far as bone marrow edema and fluid. Then we will talk about the meniscus, and last we will talk about the ACL. And then Sajeer will show some cases in between, and then we'll discuss some common clinical conundrums that we come across. So that is the basis of today's talk. We don't want to get into too much detail of things like cartilage and other and patellofemoral and other areas. We will leave that for a different session. That way it gives us enough time to address all the issues that come up in these three large areas. So I'm going to go ahead and share my screen. And first you will see Sajeer's face. No, first you will see basically this is an MRI of the knee. Hopefully most of you know what this looks like. Now the sequences that we use. So with MRI, one of the things that we want to do is we always want to see different structures and what they appear like. So the sequences that we typically use in our practice for patients with internal derangements is we like to keep it simple. I'm like an orthopedic surgeon. I think very simply. If they show me too many complicated sequences, I get confused. So I normally take one sequence, which is this one here on the right, which you can see, which I'm scrolling across. And that is the one where we basically have the image looking black. And the only thing that's bright here is fluid. So you can see this area here, that's fluid, that's bright. And the other thing you will see the marrow, the fat has been suppressed. You can see this little fluid here that is bright. And the other thing that you can see in this sequence oftentimes is if there is bone marrow edema within the bone, then that will appear bright. So fluid and bone edema appear bright, and these are very good friends of ours whenever we're reading MRI, as you will see as time comes. And the other sequences that we get are axial, sagittal, and coronal sequences in what we call is the proton density images. So I'm going to make this here rows, and I'm going to keep all three open so that I can I'll show you that. So anyway, this is the sagittal sequence. So we're slicing across, as you can see the green arrow moving on the axial image. So this is how we're slicing sagittally. This is coronal from front to back. This is sagittal from medial to lateral. And this is axial from top to bottom. So these are the three ways that we will slice our MRI sequences or our knee, and we'll look at it. Now, let me not waste any time and just go straight into how we start reading. So the first thing I do is I look at the fat suppressed images. These are the most helpful images in terms of how you start looking at things. And what I look for here is typically areas of bone marrow edema. And the classic areas of bone marrow edema that you will see are here along the posterior aspect of the medial tibial plateau, especially in ACL injuries. Sometimes you'll see them far in the periphery of the medial femoral condyle when you have an MCL avulsion. Other areas that you commonly see bone marrow edema is at the femoral, at the tibial attachment of the ACL. If you see a little bit of degeneration in this ACL, sometimes you can see cystic changes and edema over here. So this is a common area for edema. Sometimes you can see at the meniscal root attachments. And laterally, the common areas are the posterior lateral tibial plateau as well as the sulcus terminalis, which all of you know are classic areas for people who have a ACL injury. Sometimes you'll see edema not here, but more anteriorly here. And when you see it more anteriorly on the femoral condyle, you should start thinking that somebody could have had a patellar dislocation event, in which case you will see anterolateral femoral bone marrow edema. And you will also look consequently to see if there's inferomedial patellar bone marrow edema. So that is the typical impaction pattern that you see with that, right? So once we look for bone edema, we look for fluid. We want to see if there's a joint effusion or not. We want to see if there's a parameniscal cyst or not. We want to see if there is a Baker's cyst more posteriorly or not. So these will be some of the things that we will see on this fat suppressed sequence. Once we've seen the fat suppressed sequence, I go into what's called a compartmental-wise approach. So what I start out normally is by saying, okay, I'm looking at the medial femorotibial compartment. So we know that this is medial, right? Because when we look at the medial images, what we notice first is something that many orthopedic surgeons like to talk about, which is called the golf ball on a tee appearance. In other words, this is a triangle, and this is the golf ball sitting on top of the triangle, and that's the medial femorotibial compartment. You can practically hit this ball off. And when you look laterally here, you can see this is not quite the same triangle. It's a right angle triangle, not the isosceles triangle that you see here. And that's the lateral femorotibial compartment. The first thing we look at is the cartilage lining. So this gray area here is the cartilage lining. And you can see here on the MR images how you can see the cartilage lining really well. This is the subchondral bone. This is the superficial layer of cartilage, which is black. Then you have the gray layer, which is the transitional zone. You have a deep layer, which is the critical zone. The radial zone. And then this overlying this black triangle here is the meniscus. So we start by looking at the cartilage. Then we look at the meniscus. Now remember, there are some areas to look at very carefully when we look at the meniscus. From back to front. So as we come more posteriorly, the thing that we want to be very sure that we look at is the posterior horn medial meniscal root. This is particularly important in older patients who come with acute pain because they can have root tears. So you want to make sure that this root goes all the way down. We look at the body segment to see if there's any extrusion of the body. The moment you see extrusion, you have to be very careful because you know that there's probably a tear or some degeneration. And here on the sagittal images, we look at the posterior horn, especially to see if there's a tear. Remember, there can be a little bit of high signal posteriorly because of the vascular pedicle. Okay. Superficial to this, we look at the medial collateral ligament, which is this black band of tissue here. So this is the medial collateral ligament. That basically takes care of us looking at our medial femorotibial compartment. Laterally, when we start to look, we'll again look at the bone marrow edema, the cartilage. You can see the lateral meniscus. Look at it on both the coronal as well as the sagittal planes. And you can see this nice bow tie appearance. If you find that you're seeing this sort of less bow tie appearance, as you scan through more of this joint, then you know you're dealing with a discoid lateral meniscus, and that's another thing you should look for very carefully. When we start to look at the anatomy a little bit more closely, again, now when we go in the coronal images from anterior to posterior, this band-like structure here is the iliotibial band. Remember, you'll often see a little bit of scarring and edema between the iliotibial band and the lateral femoral condyle. This may or may not be associated with iliotibial band friction syndrome. So you want to look for that. As you go a little further behind, here, this little strand-like structure here, just behind the iliotibial band, as you come a little further back, is going to be the world famous anterolateral ligament. This is its tibial attachment, and this is the strandy thing that goes up here. I think this is a piece of bogus ligament, but I'll leave that for another day in discussion. This here is the fibulocollateral ligament. You can see it tracking from the fibula going all the way up here to the femoral condyle. And along with it, that forms the conjoint tendon is the biceps tendon. So these two get together and form the conjoint tendon. And then as you look a little bit further behind here, this is the popliteus tendon, this band-like tissue that comes up, and it comes up here, and it's the popliteus tendon. And you can see these structures very nicely on the axial images as well. So this here is the popliteus tendon up here, and you can track it down here as it comes to the muscle. Okay. And this band here is the fibulocollateral ligament. So these are the lateral structures primarily. As we get a little further behind, one of the things that everybody wants to see is oftentimes the popliteofibular ligament. So here you can see is the popliteus tendon, here you can see is the fibula, and here you can see this ligament going across, which is the popliteofibular ligament, or a condensation of the posterolateral capsule. Okay, so this is for your PLC structures. Next, we move on to the extensor mechanism. We want to see the quadriceps tendon above, the patellar tendon below. Here's the patella itself. And then here is the articular cartilage. You can see the cartilage lining very nicely. Here, in fact, is a great place to look at all the cartilage structures. So you can see the superficial layer, which is this black layer, the transitional zone, which is this gray layer, and the radial zone, which is down here, which is at the junction between the subchondral bone and the cartilage. These here are your medial and lateral patellofemoral ligaments, the strandy structures here. And posteriorly here is what you want to look at is your popliteal neurovascular bundle. And especially in patients who have any sort of motor vehicle accident and you get those multiligamentous injuries, do make sure you spend time to look at these little dots over here. Trace them. This is essentially your sciatic nerve as it splits into the tibial and common peroneal trunks. And you can see the peroneal nerve here tracking down, going all the way here along the neck of the fibula. And when you have any fibular injury, you want to make sure that you're not causing any injury to that. So with this, we basically covered the entire segment on how we look at the MRI, what are the common structures we look at, and how we go about them. So I'm not sure if we want to pause right now with the anatomy, or let's just move on to starting the first section, which is on bone marrow edema. And I think that's what I'm going to do. I'm going to take the liberty of doing that. So this is a, sorry, shall we just go ahead?
Yeah, please, I think.
I have one thing.
Yes.
Yeah. Sir, like how important is the cartilogram? Like most of the time.
Yeah. So that's
like,
yeah. So Sandeep, that's a great question. So I think the reason for the cartigram is to remember as to what the thing does. So if you are looking for, when we look at cartilage, we look at it in two ways, and we should discuss this separately. Essentially, if you're looking to see if there's cartilage defects, if there's holes in the cartilage, if there's punched out holes, if there's diffuse cartilage wear, then you do not need a cartogram. The time that you need a cartogram usually, or it becomes of any use, is if you have done a cartilage filling surgery, if you've done a cartilage repair surgery of some sort, and then you want to know what is the character of what is filling that defect. Is it fibrocartilage? Is it hyaline cartilage? Is it similar to the other cartilage? Then a cartogram could have some use. But otherwise, in general, in my practice, we don't promote cartograms for anything, even though we get paid more for doing them. I don't see great value in those situations. I think the great value of a cartogram lies is possibly if you want to know the character of the cartilage defect and the adjacent cartilage, if you're planning to do a cartilage reconstructive surgery, and if you have a post-reconstructive cartilage reconstruction patient in which you want to see, is this cartilage incorporating well with the rest of the cartilage?
Thank you.
May I have a question?
Yes.
While ordering for while asking for an MRI,
yeah.
If you are looking for an ACL injury, requisition we should give to an MRI center, anything specific?
So unfortunately, there's not a very standardized way that everybody does MRIs everywhere. Everyone has fairly different, somewhat different protocols. But in general, an ACL tear, I think if you just wrote ACL tear, you wouldn't have to write anything more. There's a pretty standard way of scanning those in which they'll include some standard sequences. The time that you want to be a little bit careful is, in most situations, an MRI is done for an internal derangement. So they will scan it in a certain way. The time that you want to be particularly careful is if you're considering somebody having an infection or if you're considering somebody having a tumor. Then the protocol changes considerably because then we take certain different sequences. We may or may not give contrast. So if your questions are infection, neoplasm, inflammatory disease, then the protocol may change significantly. But otherwise, for the most part, in our country, you give the history and the MRI center should be able to handle how to do the scan.
Aditya, how do you manage to put all these three images, sections on a single screen and then scroll the way that all three start scrolling?
So this is, do that? If you're a Mac user, then Horos or Osirix is what you're basically using. Okay. And when you do this, what you have are a few different options. So one is you can have all the screens here. You can open up, if you right click on any of the images, you can open up multiple screens. And when you come into the section on 2D viewer up here, in 2D viewer, you have an option here as you come down of row tiling. And you can, for example, to say you want just one row, in which case all the images will be in just one row and you can see them all. And when you go into your Horos preferences and you go into an area called your hotkeys, which is here, then what you can see is I have set it up so that if you look at double click, there's a function called 3D position. And I put it on double click. So what that allows me to do is if I, for example, see something over here and I want to know, oh, where is this structure? And I double click on it. What essentially happens is, I'm just going to zoom out because it sort of, but if I see this structure and I double click on it, what it does is it shows me a crosshair on exactly the same structure here and here.
So it gives you coordinates where
it allows me to 3D triangulate, yes.
Okay, perfect.
And otherwise, there's a feature called scout lines. So when you again go to this 2D viewer, you go down to the annotation section. There's a section here called graphics, and you can say basic graphic. They have an annotation. They have a section called a scout line. And essentially, this scout line will appear so you know how you're scrolling and where you're at.
Oh, perfect. I think that's a good tip. Thank you.
Right. And this is, by the way, just one thing separate. Well, we'll talk about it later, I think, when we come to. I don't want to waste more time. Okay, so are we good with this? Should we keep going? All right, great. So this is a part of a talk that I did with Malini during the last YROC conference. It was quite well received and is generally about knee MRI for orthopedic surgeons. What we'll talk a little bit about sequences and anatomy. I'm not going to focus on this. We've already talked about this and we're focusing on internal derangement, so I'm not going to confuse life any further. I think we'll skip through this part. What we're going to talk about here is the first thing that you do when you look at it is you look for fluid and edema. And here the key thing is, one is, do you identify normal and abnormal fluid? Do you identify bone marrow edema? Once you see bone marrow edema, it's important to characterize it. Do you think this is from trauma? Do you think this is from insufficiency? Do you think this is degenerative? And then you characterize the fluid. And then we're going to mention a little bit at the end of this on soft tissue edema, and that we're going to talk about timing of MRI scans and how that makes a difference to what you read. So I think when we look at bone marrow edema, the important thing for everybody to remember here is that you can have traumatic bone marrow edema, you can have insufficiency bone marrow edema, you can have degenerative, you can have infectious, inflammatory, or neoplastic edema. And when we think about traumatic bone marrow edema, we can have it because of impaction, which could be an internal impaction, that's two bones colliding against each other, or external impaction, which means like a hammer coming from outside and slamming against something. And you can have avulsional edema. So for example, your MCL peeling off the femoral condyle. So that can lead to edema, so that underlying bone gets reactive changes. We'll talk a little bit about subchondral insufficiency fractures and stress. We'll talk about degenerative bone marrow edema, and maybe we'll touch on infection and inflammation. And then finally, we'll talk about fluid, what is normal, abnormal, and what we should do with fluid. So let's look at traumatic bone marrow edema. I think we're all aware of some standard impaction patterns. So if we think about how an ACL is typically injured as a valgus external rotation injury, we know that there is impaction that happens laterally, so along the lateral compartment. And we know that there is some element of impaction that happens at the inner aspect of the medial femoral compartment. And that is what gives us essentially this classic lateral femoral condyle sulcus terminalis, posterior lateral tibial translational edema, as well as this posterior medial tibial bone marrow edema. So when you see this bone marrow edema, it's pretty classic, and you can pretty much, just from looking at the bone marrow edema, say that this patient's ACL is probably gone. Similarly, you can have an impactional bone marrow edema anteriorly here at the tibial tuberosity, which makes you think of a dashboard injury, and you know this patient is probably going to develop or have a PCL injury. And similarly, you can have this sort of kissing contusions anteriorly in somebody who's had a hyperextension injury and who would also potentially be a PCL rupture. You can have impactional injuries we talked about earlier. So for example, you can imagine that this patella, which was sitting here, jumped out here. This part of the patella collided against this part of the femur, and therefore we have these bone marrow edema patterns here on the medial patella as well as the lateral femur. So this is your pretty classic patellar dislocation impactional edema. Similarly, you can have a patient who's had a clip injury. You see there's the valgus loading, the MCL injury here. With the MCL injury, you can see that there's bone marrow edema from avulsion on the medial side. And you can see impactional bone marrow edema because these two areas will impact against each other, and you see this bone marrow edema. So just reading the bone marrow edema, understanding it, gives you a good idea of the biomechanics of injury that we're dealing with. In kids, sometimes you can have these avulsional bone marrow edema patterns in somebody who's got a patellar sleeve avulsion. So that sort of looks at one aspect of traumatic bone marrow edema and biomechanics. If we think about subchondral bone marrow edema, it can happen for multiple different reasons though. We can have it translational, like we talked about earlier. We can have it in these kind of situations. You can see there is actually a cartilage defect here. And because this cartilage has delaminated and come off, you can see that there is some edema in the underlying bone. So anytime you see bone marrow edema, remember to look at the underlying cartilage, because there can be a cartilage abnormality there. You can have these edema patterns here, which are, if you look at this cartilage lining here and you look at the cortical bone here, you can see this thin black line that I can draw with almost a pencil. But when you come to this area of marrow edema, you can see how it sort of lifts off and becomes almost lentiform in appearance, like a lens, instead of being this flat line here. And this is what we see typically with subchondral insufficiency fractures. And this is what many people mistake and call SPONK, or spontaneous osteonecrosis, which is essentially considered to be a term of the past now. And then last, you have this kind of a bone marrow edema along with this sort of osteochondral lesion here. And this is essentially an osteochondritis dissecans lesion or an osteochondral lesion. So anytime you see bone marrow edema in the subchondral bone, think about impaction, think about cartilage, and think about osteochondral lesions. Now, just to touch on this concept of subchondral insufficiency fractures and SPONK, this, for example, is a fast bowler who we imaged in, I think this was around April of 1 year. And we had this. He came back to us. He had a little bone marrow edema with this stuff here. He came back to us a few months later without stopping his bowling. And the bone marrow edema has increased. And now you can see how that little bone irregularity is there between the bone edema and the underlying bone. And this is essentially a subchondral insufficiency fracture. And what happens to these fractures is they may undergo a process of further progression, and then they may heal, in which case we used to call them transient osteoporosis, or we would say this is, a healing subchondral fracture. On the other hand, they may progress to, this bone collapsing and then rapidly progressive osteoarthritis, in which case we used to refer them to spontaneous osteonecrosis. In fact, today we are reasonably convinced that the bone death that we see in that histologically is because of edema and resultant bone death. And there's not a primary vascular phenomenon that would happen with avascular necrosis. And essentially, when you see the subchondral bone marrow edema, you should think very carefully of subchondral insufficiency fracture. These patients should typically be rested, offloaded, and possibly put on vitamin D supplementation as well as other bone forming agents in order to make sure this thing heals well, rather than to sort of say that, this will go on its own or do something else. So I think this is an important phenomenon for everybody to understand. Other causes, you can have stress fractures, you can have an osteophyte that fractures. This is very typical of the older patients. This is the more classic serpiginous pattern that we see in patients who have avascular necrosis. So this is proper avascular necrosis. And then this is sort of, you can see these small little cystic hole-like spaces over here along with bone marrow edema. And you can see that the cartilage has completely gone across the femoral as well as the tibial sides. And this is typical osteoarthritic bone marrow edema. In infection, you can see actual scalloping of bone and erosive changes along with a big synovitis. And in fluid, the common areas we'll see fluid in the suprapatellar recess, posteriorly in Baker's cyst. Now remember, when you have your patients with Baker's cysts and leg pain, remember to look to see if that fluid is leaking or if there's more edema behind, because leaking Baker's cysts can cause a lot of pain. So a ruptured Baker's cyst with edema sort of streaky like this is an important thing to identify. And then you can have obviously deep infrapatellar bursa here, and then you can have pes anserine bursal fluid. So these are some common locations for fluid in the normal and abnormal situations. When we look at fluid, we can look at the synovium as well. We can see sort of a smooth reactive synovium here. We can see a thick reactive synovium here. We can see in this patient with post-knee arthroplasty sort of nodular synovium, which looks very much like particulate debris. And we can see a rather heterogeneous, shaggy appearing synovium here, which is more typical of infection. So the first thing we're going to do, I know this is step 2, is to identify normal and abnormal fluid, characterize it if we see it, identify bone marrow edema, try and characterize it. Do we think it's traumatic, infectious, inflammatory? If it's traumatic, is it impactional, avulsional? Does it tell us about the biomechanics of the disease? Then we look at degenerative bone marrow edema and see if it's just an acute exacerbation of degenerative change. And then we've talked about the concept of spontaneous osteonecrosis versus what we call more appropriately now a subchondral insufficiency fracture, or SCI. Last but not least, I just wanted to put a word in. When we image patients early, we tend to see more edema. So we may over exaggerate injuries, whereas when we image them late, so early, I mean, if within the first week, and especially within the first 2 days, if we image them further out, like after 3-4 weeks, then structures that have torn and stretched may remodel and give you sort of its appearance of laxity. You can't see the laxity. The structure looks continuous. And you say, you get an MRI, you say that, oh, this person has posterolateral instability. And you've got this MRI that says everything looks continuous. And you say, you guys are nuts, there's posterolateral instability. And that's because that structure has healed, but it's healed in a lax way. So clinically, you're seeing laxity, but on MR, the structure looks continuous. And similarly, early on, we'll say, oh, this looks like a high-grade injury. This looks like, whatever else. But if you look at it a few days later, it'll look like it's more like intermediate grade or median. And this is especially true for something like the MCL, which remodels well. So with that, I will pause and let Sajeer take over and talk about some of the things with which he wanted to show as far as these entities go.
Wonderful.
Yeah,
so as you say, Aditya, sorry, sponk is quite rare. That means, I mean, it's more like an insufficiency fracture.
Yes, it's almost all. So today the thinking is that this is a spontaneous, this is an insufficiency fracture. It is not spontaneous osteonecrosis. In the theory sort of started out in the hip, where they used to talk a lot about transient osteoporosis and spontaneous osteonecrosis. Okay. And if you ask radiologists from the 90s, they said we gave transient osteoporosis all the time. Yeah. But if you ask them now, almost all of them say we almost never give it. We just call it subchondral insufficiency fracture.
A lot of times in an arthritic knee, an osteochondral defect is reported. So is an OCD kind of lesion seen in osteoarthritis, or is it essentially a subchondral insufficiency along with subedema?
Yeah. So I think the key thing is what they're describing it as. If they say it's just subchondral bone marrow edema, then usually it ends up being acute exacerbation of osteoarthrosis. So acute exacerbation of osteoarthrosis is nothing but a subchondral insufficiency fracture in an osteoarthritic patient, whereas a subchondral insufficiency fracture is otherwise just a subchondral insufficiency fracture in somebody who's got good cartilage.
Perfect. I think overdiagnosis happens.
Yeah,
great. Thank you.
Okay,
Sajeer, we can continue, please.
Yeah, so we thought when we were starting this presentation together with Daftary, we thought that we would stick to the basics and stick to only ACL and the meniscus today, because when we compiled the talk, it was too long. So essentially now Daftary has already spoken about how to go about the bone impact, find them, and deduce what kind of injury the patient had. So most of my experience, I'm an orthopedic surgeon. I work at sportsmed. I'm closely associated with Dr. Anand Joshi, and most of my work revolves around the clinic. So I work in close association with Daftary as well. So I get to learn all these images from him only. So prior to me reading and understanding the MRI, the usual thing that I used to do was just see the reports. Like for this patient, who was a 40-year-old low demand individual who came with an injury, all his ligaments were reported as torn: anterior cruciate, posterior cruciate, medial collateral, lateral collateral. So once you see the report and then you see the images, you start believing, like, are they really torn? Like here, there is an intensity towards the PCL and the ACL does appear torn. Where to start treating this patient? But if you see the right images and you observe closely, you can find that majority of these ligaments are really intact. And if you understand the injury pattern of this patient who had slip and fall in the washroom and his knee had gone into splits. So he had a valgus injury, and that valgus injury created the classic impact bruise on his lateral femoral condyle. And the only thing that he really had a stretch of the inner side medial collateral ligament towards its femoral attachment. So only thing that he really had was a high-grade femoral side MCL injury, which was conserved because he was low demand and he had a firm endpoint valgus stress. He's almost 3 years post his injury now. So when it comes to timing of imaging, such impact bruise helps us a lot to understand the kind of injury, the pattern of injury, and what happened to this patient really. So there are the various schools of thought who says that we should do a delayed imaging, like 2 weeks post the injury once the acuteness settle. Some prefer after the swelling is completely resolved to plan the surgery. So let's see a couple of cases like this electrician. He fell from a small height, like 2 feet, 4 feet height. He had a slip and fall, and he twisted his knee badly. He had developed swelling, and then he was seen by an orthopedic surgeon, diagnosed as ACL injury, and he was put on a plaster of Paris cast. And we saw him 6 weeks after his injury. When we removed his cast, he had a stiff knee with a restricted range to this, and maybe a 10-degree fixed flexion deformity. His MRI did reveal that his ACL was completely torn, but additionally, he had a large displaced buccal tear of the lateral meniscus. This complicates things because on arthroscopic evaluation, after we got a little bit of his range back, we got into surgery and we found that his meniscus was completely rounded off, refusing to reduce, and we were unable to even get it back into position. This patient ultimately ended up with a resection. Early imaging could have probably saved his meniscus. Similarly, a patient who had a footballer who had a twisting injury on field and some amount of contact as well, he was in fact carried off the field and he had a significant instability, indicating that probably it is more than a one ligament injury involvement. He was carried off the field and he came to us. We did his early MRI. The ACL is obviously torn, but if you observe the PCL too had high-grade intensity towards its femoral attachment, indicating that this is a combined injury. So in such injuries, we like to customize the post-injury management a little bit by giving a brace, keeping them in a push knee splint or a hyperextension brace in the initial 4 to 6 weeks post-injury, so that we allow some natural healing of the PCL to occur if it does. Similar thing goes with such subtle fractures, which we can't pick up on X-rays, and probably CT also can't pick up such hairline fractures which are undisplaced. And such patients who have a significant impact bruise may even have a significant fracture of the lateral femoral condyle or the lateral tibial plateau. And in such cases, we like to offload the knee and not put pressure on the leg for at least 4 to 6 weeks prior to we considering prehab or planning the next step. Such injuries are quite straightforward. We know that the medial collateral ligament towards its tibial attachment is completely ruptured in this case, and it would be a straightforward case for repair, and with the timely intervention we can reattach this to its native attachment. But like this footballer from the Northeast, he just pivoted on the field and he felt a pop laterally. He did not fall, he just felt lateral side pain and a feeling of give way. No swelling. He came to us, we checked his MRI, we checked him clinically first. We observed that he has a tenderness on towards the fibula head. And his MRI did reveal that the lateral collateral ligament towards its fibular attachment was completely discontinuous, and we could identify and repair this in the early stage itself with suture anchors onto the fibula head. Now this case is interesting because he's a footballer from Goa. He had a twisting injury and he was taped by a rehab specialist, and he was advised to wait for a couple of days, weeks prior to doing an MRI so that the swelling subsides. His clinical examination was very fishy because he couldn't do a straight leg raising. The ACL was definitely torn in him, but if you closely observe, the patella tendon was involved too, and it was in fact fully shattered. We did a first stage patella tendon repair in this case, followed by a second stage ACL. Coming to chondral injuries, where subtle chondral injuries can be conserved and if not treated, if not imaged early is okay, but this 19-year-old girl with a patellar dislocation history and a large chondral fragment, since we could intervene early, we could reattach this to its native position, especially since it's a 19-year-old girl. Probably we could get a better result with reattachment rather than excision at a later stage. So early imaging does have advantages. It completes the knee injury assessment. It gives us an idea whether about the 10% cases which needs early intervention. And it also customizes the initial post-injury management in some patient who needs bracing, some patients who need non-weight bearing. It can pick up injuries from major tendon injuries like the one I showed to subtle collateral ligament injuries. And I think it's a key thing in chondral injury management. So now I think Daftary is going to talk about the meniscal lesions and how to read them before we correlate it arthroscopically.
Sajeer, I mean, there are a couple of questions I think coming in. So let me start with the question. I mean, in a multi-ligament injury, if you suspect, so for you, it's day one MRI is prescribed.
If it is possible, day one. If it is a very tense hemarthrosis and highly unstable knee where we can't get him into the machine, we probably would wait a couple of days prior to getting the MR. Very rarely we have done a hemarthrosis aspiration and got the MRI done in some cases where we really need the diagnosis.
So I think the other thing IPS is to, in terms of why we do early imaging, is often primary reason to do it is if we feel for any reason the clinical examination is limited and that we could potentially find something that would need a more urgent intervention. And the classic example, like Sajeer spoke of, was you have a patient who you know has who you think has an ACL rupture, but you examine them and it doesn't seem like it's a lax knee. And then now you're concerned if this person could have a bucket meniscus, because that bucket meniscus you would go for urgently and fix that, because you have your best chance of getting to it is to get it to it early. And then you might leave the ACL for later on to let all the bone marrow edema and all that settle and then go for that. But you don't want to miss out that. And you also don't want to be in that sort of situation where clinically this doesn't seem like it's an ACL, but I'm quite sure there's an ACL. And then sort of the MR helps you to just put that whole picture in place.
But I think reading an MRI is more important, because sometimes a lot of edema confuses you and they end up in reporting that, as Sajeer rightly showed, that everything is torn. I mean,
yes.
Probably would.
So I think you have to go in sort of in the beginning when you're looking at an acute MRI. It's like you're reading everything with a pinch of salt.
Yeah.
And when you're reading an MRI delayed, you're reading with a fine-tooth comb, because now you're looking for all the little things. Whereas when everything looks exaggerated. So, and this is especially true for structures that remodel. So say, for example, the MCL, it remodels well. A PCL potentially would remodel well. The posterolateral corner would potentially remodel well. So if you see edema in those areas early, it's great. You can say, okay, these structures are affected. Now I'll see you 6 weeks later, and how much laxity do you have? How much pain do you have? How much tenderness do you have? And I'll decide, am I going to fix this? Am I going to leave it? Perfect. As opposed to if you just saw somebody scanned at 6 weeks, then you would not have a sense of what happened earlier on in that imaging.
Yeah.
So, and the key thing, I think, where it comes to you guys is somebody may come to see you, 6 weeks after an injury. You get a fresh MRI, you look at it and you say, oh, everything looks, this way. Yeah. And then when you ask them, did you get an earlier MRI? And they say yes. And you look at that earlier MRI, you will find all those things in that. Absolutely. And then you say, okay, now it makes sense.
Makes sense. Thank you. Yeah, Bhupesh, you had a question.
Thank you, both of you, for the radiology perspective and orthopedic perspective. So I just wanted to take a closure on what we were just discussing with relation to only ACL and subtle small meniscal tears, which is the most common presentation as orthopedic surgeons we see. So what is the wise thing to do? Send them early for MRI, because many times we see that Latchman has got a hard endpoint, but because of the early edema in ACL, I'm talking only in relation to ACL, and there is edema and it is reported as partial tear or complete tear, and patient is panicky. That is one scenario. Second scenario, what is the use of hemarthrosis in relation to imaging? Because as an orthopedic surgeon, I always thought this would act like contrast. There is already some fluid inside. So small meniscal tears, the fluid will seep in and we will kind of see it better. So is it a good practice to evacuate it and then send it to you for MRI, or hold the hemarthrosis and send it to you, because smaller lesions, as these fluid can seep into smaller tears, you can find them better. So my third question,
I think let's the answer too.
Let's go one at a time. So first, in terms of the small ACL and meniscal lesions, I think we'll talk about these as we go to those sections. If you have questions about those, let's deal with those then. The second question about the hemarthrosis, it's a good question. Personally, my thing is, I don't care. The fact that fluid tracks into the tear and all is all humbug. It doesn't matter at all. The key thing over there actually is, if you put a needle into somebody's joint and you get extensive air into the joint, then that becomes actually a confounding problem for me sometimes. So if you're going to image somebody, unless you have to aspirate, because otherwise the patient won't get into the scanner or some reason, and it's not like we can't read around the air, we definitely can. At worst, we'll see it's a little bit of an artifact or something. It's not that big and bad. It's not like putting a big, hunk of something bad into the joint. So honestly, the hemarthrosis is not an issue.
Probably we do maybe 10 hemarthrosis aspiration a year.
Yeah.
That's the number.
So yeah, our hemarthrosis evacuation also is almost nil. We stopped doing it. Now, the other question, Dr. Sajeer, you showed a lateral sided injury of a footballer. Okay. Now, many a times we get, I'm generally saying, we see a lot of lateral sided injuries reported in the MRI which do not clinically fall in place. And I understand there is something to do with something called the magic angle artifact that the LCL makes or whatever. Can you throw some light on that? What is the magic angle artifact and why LCL injuries are always a problem to quantify?
Okay, so the problem with the LCL, let me do this. Let me share my screen with you for a second. Okay, and I'm going to show you okay, so here is, can you see my, one second?
No, you need
yeah, I know, I moved this out here. Let me get this. Okay, so now when we look at the lateral complex, essentially, what happens is, remember that we are taking a straight coronal image. If you see this line, it's going straight back and forth. Okay, if we look at the fibular collateral ligament, which is essentially this little thin band of tissue here, all right, we are down here at the fibular tip now. You can see this is the fibula. As I'm coming up, this band of tissue anteriorly, you see this guy? That is the fibular collateral ligament that I'm slicing through.
Yeah.
Okay.
Yeah.
And when you slice through it, as I come up, okay, it goes from anterior to posterior. The start is more anterior and the end is more posterior. Do you get that?
Yeah.
Can you see this? Yeah. So if I were to show you this is one arrow. I'm going to copy this arrow and we're going to go down to the bottom of this, where this ligament is. You can see this, sorry, it's more like anterior. So this is posterior and this is more anterior. You see that? So it's running an oblique course.
Correct.
Now, when you see this on the coronal image, it's a straight image. So essentially, on no single image are you seeing the entire fibular collateral ligament. Okay? On no single coronal image will you see the entire fibular collateral ligament, because the coronal sections run obliquely through the fibular collateral ligament. Am I making sense?
Yeah, I understand.
Right?
I understand.
So therefore, what happens is, if you're not scrolling through this properly, you will tend to average with adjacent tissues. And when you average with adjacent tissues, then structures look like they have an element of high signal inside them.
Okay.
And that is what then gets misconstrued as an ACL, as a fibular collateral ligament injury.
Okay.
That being said, that is not the concept of the magic angle. The magic angle is an MRI phenomenon that comes for certain structures in certain obliquities because of the magnetic field and the way it is aligned. But that is not really an issue here. If you start looking at structures in 3 planes, then magic angle is not really an issue you should worry about.
Okay, thank you.
Okay.
Just to add one comment to Bhupesh's question. 2 case scenarios where we really intervene and we really think that's a complete rupture.
Yeah.
Is a structure discontinuity and a curled up ligaments. If
Yes.
you find these 2 on the MRI, you can really be sure that you're going to find a detached or a discontinuous, be it mid-substance, distal attachment, proximal attachment, injuries of the ligament.
And a bony avulsion. The third thing is a bony avulsion. If you see a bony avulsion and you want to know, then you definitely want to know the size of the bony avulsion, because you're going to decide whether you're going to screw it back or you're just going to take it off, and how you're going to fix it back. So I think 3 things. So if it's a full discontinuity, so normally if it's just partially discontinuous or if it looks partly complete, then people will just wait on it. If it's complete discontinuity, then obviously you may decide to do something, but then it doesn't matter whether you do it early or late. But if it's bony disruption, then you would probably intervene early, because that's the time you want to really stick it back and give it its best chance of healing.
Perfect.
Yeah, perfect. Thank you.
Aditya, I've got a question for you.
Yeah, Samanta. And then Sandeep.
Thing is that, yeah. No, Sandeep, you can go ahead then.
First, you go ahead, sir. Then I'll ask. Please ask, sir.
Okay, sometimes we see because this is a common question for the juniors, is that because with ACL is an oblique structure, probably in some form, if the MRI guy is not very good and he's not very good at reporting, then probably the junior guys, they miss sometimes the ACL as the partial here. Do you suggest to classically to tell our juniors that whenever they go to the console, they must take the oblique sagittals? Do you suggest that, or you just
no? So again, what I'll show you in the ACL section is, I think the key thing here is you start looking at the structures in more than one plane, and then you don't need to get additional things. So we have a standard rule in MRI, there's no free lunch. The moment you want to do something more, it takes more time on the scanner. The moment it takes more time on the scanner, it's a headache. So the question is how we can work around it. And looking at the structure in 3 planes is the best way to look at things. And you will get much more information than doing these additional sequences for just small little things.
Sir, I have one question.
Yes, Sandeep.
So, sir, when and how important is the dynamic MRI of the knee?
We don't use it in our practice at all. The questions are always in terms of what you want to do. I think some people have used sort of kinesiometers to show that there's translation of the ACL, or there's translation of the bones and indicating that there's ligamentous disruption. I think these things are seen very well with radiographs, so you don't really need to go down this path. I think some people have thought about using dynamic imaging for seeing if there's dynamic meniscal extrusion as being something that we can see. Honestly, something that I have pushed our practice for the longest time, but we never really had the big need to do it, is you can even look at these things with ultrasound. You know, you can have somebody lying down, look at their meniscus, and you can have them standing up and see if it extrudes more. So you can use these things. These are the 2 big reasons I can see why I use dynamic imaging. Sometimes people want to say that we can see dynamic patellar tracking or something like that. I'm not sure to what end. I mean, clinically, you can see half those things. It's not like something hiding inside the knee joint that you want to see. So I don't see a big role for it per se. And that being said, when you talk to the people who have dynamic MRI machines, they will tell you everything that's great about it. When you talk to those who don't have dynamic MRI machines, they'll tell you it's a waste of time. But it's, you know, if I have a hammer and there's a nail, then I can do it. If there's a screw, then that's not the right way to do it. You know, I mean, so. But I don't see. And the other problem with dynamic MRI usually is that these are done on lower field scanners. So they are 0.2 or 0.5 Tesla scanners. So the resolution of the image that you get is nowhere near as good as you would get on a 1.5 or a 3 Tesla scanner. So, you know, buck for buck, I would take a regular closed scanner way over dynamic MRI in any way, shape, or form.
I think then we can continue. Yeah.
Okay. Aditya and Sajeer, as you told that during because of when there is posterolateral corner injury, in the acute it is very difficult, or sometimes it is exaggerated, that some tissues might be looking like exaggerated thing. So how you suggest, because posterolateral corners, when we go ahead with the repairs, probably we do the repairs like around 7-10 days time, because if it's more than 10, it is very hard to do the repair and whatever. So do you suggest we have to wait for 3-4 days just to have a better picture, or immediately go ahead with the MR?
No, so this is my understanding. So again, we follow the same principles. If you look at somebody who has an MRI, whether you've done it early or late, preferably even if you've done it early, what you will see is a lot of edema. What you will see is a structure is continuous, but there is edema, or you will see a structure that is discontinuous and edema, or you will see bony avulsion with edema. So if you see a structure that looks continuous with edema, then you would probably say, let's just wait and watch, because we want to see how this structure will remodel over time. So in which case you'll say, we don't need to reconstruct this urgently. If at all you're going to end up doing something as a posterolateral reconstruction that's going to be delayed, which is fine. If you have somebody who has a actual avulsion or a bony avulsion, that's when you want to do something acutely. That you can tell when you do an early MRI, that you can tell no problem at all. So the key thing, I suppose, is that when you do an early MRI, does the structure look continuous with edema, or is it discontinuous with edema? If it's discontinuous with edema, then you're probably more inclined to intervene earlier. But if it's continuous with edema, you're more likely to give it the benefit of doubt and say, let's wait, let's see how well it remodels, let's see if the other body tissues take over, and if we actually need to go back and do a reconstruction. Because it's not just about that particular structure, it's about the entire biomechanical chain that's holding that structure together. Sajeer, you want to add something?
In these times, how frequently can we do an MRI? See, let us say
how much money you got? How much money you got? How much money you got?
No,
how much money you got?
Scientifically speaking,
like I told to
for the edema to settle down, should we wait for 5 days? Is there a thumb rule, or should I wait?
I don't think you should worry too much about the edema.
That was my question. Bhupesh, you are at that point only because for the lateral corner injury, you are very aggressive about whatever we do the MRI and go ahead with it. Probably the best time of doing operation is like 5 to 10 days.
I think the best time to operate 5 to 10 days if you have a complete rupture, which you can tell. That's not an issue. You're not probably going to go in with somebody who has a stretch injury that could ultimately go into sort of laxity. So this is not a problem. If you scan them on day 1, day 5, day 10, I will tell you structure is discontinuous or continuous. That's not going to make a difference. So your primary clinical question, is the structure discontinuous or continuous? That I will answer irrespective of if you scan on day 1, 2, 5, 10, 15, 20.
Okay.
So timing of the MRI doesn't make a difference in diagnosing grade 3 ruptures. That's what the
yes.
Yeah, because that I want to stress because of the if you do the acutely, probably there are a lot of edema and whatever, because we orthopedic surgeon not like whatever Aditya is telling, like we are not that like seeing sometimes like your coronal section, probably sometimes we see like your LCLs. In axial cuts, it's very difficult to train our eyes to see the LCL, to follow the whole thing in different films, like what you show in the console. It is very difficult for us to understand. We see at least 50 like LCL in the axial cuts in the consoles.
Right.
Now, Daftary, would you like to go ahead with your talk? It's already...
Okay, let's just keep forging ahead now. We're going to move on to the section on looking at the menisci. Okay. So here we're going to talk about, is my screen shared? No. Is it?
No, not yet.
Okay, let me share my screen. Sorry. Okay. Now?
Yeah.
Okay. So what we're going to talk about is normal meniscus. We're going to talk about this great concept of grade 2 signal, which drives every orthopedic surgeon completely mental. We're going to talk about some common meniscal tears, some normal variants, some easily missed tears, and we'll talk a little bit about the fixable tear. So the normal meniscus, I think the key things to remember, it's a black bow tie shaped structure in the sagittal plane or triangular on the coronal plane. So bow tie means like this, right? This is the bow tie, right? So this is your meniscus normal structure, right? This bow tie appearance. If you wanted to, you can draw the guy's head and 2 eyes and ears and whatever else, and you can see, right? If you look on the coronal images, it tends to be triangular like this. So this is your normal appearance of the meniscus. If this triangle, especially laterally, fills up too much, you start to think about a discoid meniscus. This here is the lateral meniscus, again with this bow tie appearance. And these structures back here are your suspensory ligaments, your coronary ligaments that hold the meniscus to the meniscocapsular junction. So this is the superior and the inferior ligaments medially, and then these are the ligaments laterally. So this is what your normal meniscus looks like. Typically, it should have a nice black signal within it. And you should see no signal inside this meniscus as such, okay? What are the variations of signal you can see? So you can see normal signal. You can see this hazy signal, which was what people call grade 1 signal. You can see this, again, hazy signal that's more linear, but doesn't quite go down to articular surface. In general, the rule of thumb is if you have to squint to reach the articular surface, then it's probably not a tear. Then you have this, especially in younger people, you see this, it's sort of curvilinear appearance like this. And when you see that appearance, then you have to think that this is a vascular pedicle. And this is especially true if you have a young, under 30 patient and somebody says horizontal cleavage tear. Horizontal cleavage tears don't happen in young people typically. So this is more likely to be a vascular pedicle. So especially in that patient, and you have this sort of vascular pedicle appearance, you don't have clinical signs of meniscal, of joint line tenderness, and somebody's reported a meniscal tear, then you're going to say, that's nothing really. This is the more famous one, this grade 2 meniscal signal. And this is what radiologists like. We see meniscal signal, it's horizontal. but it's not reaching articular surface. Oops, sorry. And when we see horizontal high signal that is not reaching articular surface, we say this is grade 2 signal because we have nothing better to say. When they've looked at this across patients over time, what they found is if patients have strong meniscal signs at arthroscopy, they end up being tears. If they do not have strong meniscal signs, then at arthroscopy, they do not end up being meniscal tears. So that is also old data before our imaging resolution has improved significantly. Today, the number of cases, if we do good imaging, that we end up seeing grade 2 meniscal signal would be very, very small. The third thing is you see horizontal high signal, and along with it, you see this lobulated structure like this. So that is a parameniscal cyst. So then you know you are dealing with a horizontal cleavage tear with a parameniscal cyst. And then the question is whether you decide to go and do something about the tear or you do something about the cyst before you do something about the tear. So hopefully everyone is clear on some variation on meniscal signal. This is just meniscal signal variation before we actually reach the tear stage. So this grade 2 signal, as I talked about, what they have shown essentially that it may be a prominent vascular pedicle. I think that's the key thing to take home for all of you. And the second thing is that if it is definitely not, a small percentage can be torn at scopy. So I think if you have strong meniscal signs, there can be a meniscal tear. But if you don't have strong meniscal signs, then probably not. Now, what is other variation? So here we talked about normal, we talked about grade 1 signal, we talked about this grade 2 intersubstance signal. Then we have the more typical signal that extends all the way down to the inferior or the superior articular surface, which is your typical sort of meniscal tear, which is a grade 3 tear. And the grade 4 tear is where you see there are just multiple lines. So it's almost like a shredded meniscus with multiple different tears. Okay. So these are the variations for meniscal tears that you see on sagittal images. Now, what are some normal variants that mimic tears? So the first one you have to remember is as you come oftentimes to the anterior horn of the lateral or the medial meniscus, there is a structure here called the transverse intermeniscal ligament. And this transverse intermeniscal ligament, if you draw a line sort of at the junction of that transverse intermeniscal ligament and the anterior horn of the meniscus, what you end up seeing is this little flap-like structure here, which is essentially this little ligament we are seeing. So that is one reason you can mistake anterior horn, medial and lateral meniscal tears. And we know that isolated anterior horn and medial and lateral meniscal tears are unusual. So if you see somebody reporting them, and if you see one MRI center reporting them very regularly, then you know that that's not something that they are looking at very carefully. Along the posterior horn of the lateral meniscus, you can have volume averaging between here, which is essentially the popliteal tendon, and the lateral meniscus. And this junction over here can look like a tear. So that is how you can mimic posterior horn lateral meniscal tears. And that is towards the periphery. As you come towards the midline, you can also be mistaken with the ligament of Risberg and the lateral meniscus. So that junction can also give you this appearance. Last but not least, I think the most important thing, we see a lot of reports coming with anterior horn lateral meniscal tear or anterior horn lateral meniscus intrasubstance degeneration. Now remember, when this meniscus, the anterior horn root comes and attaches, it's not like somebody took that meniscus and just stuck it with super glue. You will find that there's small little striations and fimbriations that come in there. So to see these little striations within the meniscus like this is normal, and you should not be calling these tears. This is just anterior horn intrasubstance degenerative change, or intrasubstance, it's actually normal. Okay. When we talk about classification of meniscal tears, we obviously know horizontal are dividing into upper and lower halves. Vertical is one that goes through and through across the thickness of the meniscus, and oblique has a bit of both. And then you can have sort of radial tears and paroblique tears and bucket handle tears. Now, horizontal cleavage tear we're used to seeing on the sagittal images is this horizontal line. On the coronal images, you'll see this horizontal line, and sometimes you'll see a little parameniscal cyst or an intrameniscal cyst associated with it. The key thing to remember here is these horizontal cleavage tears, when they separate out, the lower leaf of this tear may flip out and come down here to give you this, what is called a thumbs down sign. And when you see this thumbs down sign, you know these are the ones where you get medial joint line tenderness, that's quite a bit. And when they flex and extend, you get that little clicking sort of noise with that thing, or clicking feeling. So these tears can be easily missed at arthroscopy if you just look at the top of the meniscus, but not at the bottom. So that is your thumbs down flipped meniscal tear from the horizontal cleavage tear. Radial tears can be easily missed, especially in places that don't do thin enough sections. If you do thick sections, you can miss it because it's just on one slice. So this is how literally how subtle these little radial tears can be. So this is an anterior horn lateral meniscus radial tear on a coronal image and on an axial image, which you would be hard pressed to see here on the sagittal image. It's just like a little bit of a dot. Okay. Other things with radial tears, I think what you need to look at is you can see that they're kind of small. They just sort of come and go. They sort of flash in and out of the screen. So you have to be very careful when you're looking for those. Longitudinal tears are tears that go along the length, but craniocaudally. They can be peripheral, which indicates the red zone. They can be in the middle, which is pink zone, and they can be central, which is white zone. And we try to inform you of that so you know whether the tear is fixable or not. As these meniscal tears extend, ultimately what they may go into is a situation where they may extend posteriorly and extend into that meniscocapsular junction over there and produce something like a ramp lesion. So you can have a posterior horn lateral or medial meniscal tear with an associated ramp lesion. And sometimes you can have what happens is if that whole tear buckets and then you get this bucket handle fragment here centrally displaced, which essentially gives you your bucket handle tear. And this sort of on the sagittal images will give you that classical double PCL appearance. Okay. Rarely we can see double buckets. So here you can see on this axial image that here is a bucket handle tear here with one meniscal fragment here. And then from this posterior horn, there's a second fragment here. So this is a double bucket tear over here. Sometimes these bucket handle tears will be torn in the middle. So this was the D. It gets torn in the middle and then the anterior component flips out and loops over here. So what you can pick up sometimes is this transected bucket handle tear with a flap over here. So you can see it here, the meniscus ends, and then you have that. And those, I guess, are important for repairability because a transected bucket would be harder to repair than just a plain old bucket. Discoid lateral menisci, we already talked about. I think a key thing that I always remember about discoid lateral meniscus as being a sufferer of this problem, and my daughter also being involved with it, is you can see mucinous changes within that anterior horn oftentimes. So be careful of those. We managed a lot of these conservatively. And then otherwise they have obviously a greater incidence of being of having tears in general. The posterior horn meniscal root, if you remember, I showed you the image where the meniscus comes and sort of comes down all the way till here normally. And you can see in this case, the meniscus is actually displaced here. So this is actually a root tear. And these can be difficult, easy to miss on the sagittal images. So remember to look very carefully on the posterior coronal images. And Sajeer will tell you about the complications of arthroscopy also. Post-op meniscus, just a quick word. You can see high signal, linear high signal in a post-op meniscus. Normally what we say is if you can find flaps, you can find bucket handle fragments, then you're definitely going to call something as being a retorn meniscus. If you see high signal along with strong meniscal signs, then that is a good sign of a retorn meniscus. But if you just see high signal and there are no meniscal signs, then we tend not to cause that. And in today's day and age, I don't think there's a big role for arthroscopy, for arthrography in differentiating a tear versus just a post-op change. So we've looked at the normal meniscus, we've talked about grade 2 signal, we've talked about some common meniscal tears, some normal variants, the easily missed tears, those flaps, bucket handle components, transected buckets. We've talked about fixability of a tear in terms of whether it's peripheral, red zone, and root. And then we've talked about the post-operative meniscus. So I will stop with that and let Sajeer take things from here.
Aditya, 2 questions. Number one, Aditya, can you just show how do you describe the extrusion of meniscus? How much should it go out?
Yeah, so I think the key thing over here to remember is that if we were to go back and look at this case where you have the meniscal root, so what normally one does is there is no great rule. I mean, people use some numbers and whatever else. The first thing we have to remember is that an MRI is a non-weight bearing study. So the extrusion will be more otherwise anyways, right? What you normally do is you sort of draw a line that goes along this lateral femoral condyle margin and the tibial plateau margin here at the ends over here between this area. Sorry, I'm very bad with drawing my lines without a ruler. So if you look at this to this, you draw this straight line here. And then you see how much of the meniscus is going out beyond this. And then you guys have some numbers. If it goes out more than 0.5 centimeters, then we would be considering that this is extruded. If it goes out by more than 0.5, then it's more extruded. And the point of extrusion really is that the more extruded something is, the greater the loss of hoop strength there already is. And therefore, there is more futility to going back and fixing that as opposed to a tear that has not extruded as much. So, I'm very keen on looking at dynamic extrusion with ultrasound to see if that would give us any further insight into repairability versus non-repairability.
And sometimes the bucket handle tear is rolled off. I mean, it's rounded. So can you, on an MRI, comment that this is a chronic bucket handle tear rather than an acutely? Because sometimes patient does not tell you the exact history.
Right.
He's got an ACL tear. He twists multiple times, and now he comes with a locked knee.
Yeah.
So you're never sure it is a chronic locked knee or a acutely locked knee.
Yeah. This is a tough call, IPS, but I can tell you that, if I see somebody who looks like they've had a very otherwise an acute injury on the MRI, and I see a bucket, then I would obviously be very clearly inclined to say this is an acute bucket. Whereas if I see somebody who looks like they've had a long-standing, the ACL is long gone, there's no translational bone marrow edema, and you see this bucket handle fragment, then I would say that this is probably more likely to be rolled off. Other things you can look for sometimes is you can see the margins of these. You can see this show and see if I can do one thing here. So some other things you can do, and I'm zooming this to show you. You can look at this margin over here.
Yeah, rounded.
So sometimes it looks more rounded in this, but it's not a great. I mean, I wouldn't say I would bet anything on it. If at all, I would. From your standpoint, it helps. That you could tell the patient, look, it looks a bit rounded. We'll try and see if we can fix it, but we're not 100% sure we will be able to because it looks like it may be older, as opposed to saying, it looks less rounded, it looks more acute. I'm pretty hopeful we should be able to fix this. And ultimately, the decision you'd have to make on table, unfortunately.
Perfect. And how sensitive is the ramp diagnosis on an MRI?
So what we talk about when we talk about ramp lesions is if you just see one slice on which that there's disruption of those fibers, then you're not going to get very excited about it. But if you see it, like if you see edema, this is the interface that we're looking at, right, between this and this. Okay, this is the interface that we're looking at. Sorry, brighter arrow. This area is the interface that we're looking at. So if I see a lot of edema in this interface and I see it tracking, so if I have this, this is the axial image here, this is where I'm looking. And if I see that this separation is running along a large proportion of the posterior horn, then I will tell you that, look, this is a ramp. It seems significant. I suspect this will be a more significant ramp lesion. But if I see it over a short distance, I say, look, there's some disruption of the posterior meniscocapsular junction, but it looks like it's over a short length. So I suspect it won't be unstable. But I don't think there's I'm not aware of a specific rule of thumb one can follow and say that, oh, this is definitely the case and this is not the case. So I think the combination of strong meniscal signs, absence of a meniscal tear, along with edema along the posterior lateral capsule, along the posterior meniscocapsular junction, those three things together would give you a good sense of whether somebody will have a ramp lesion or not.
The two questions have come on a chat box. Dr. Arun Gupta asks you that can you measure the diameter and length of the hamstring tendons which we need for autograft?
Yeah, we can measure those. Absolutely. Yeah.
Perfect. Another question is Dr. Shantaram wants if you can just maybe describe the post-op. How do you image a post-op meniscus repair or a meniscus?
The same way we use the same imaging techniques. We don't change anything in terms of the imaging protocol. We just account for the fact that somebody has had a meniscal tear previously. It's helpful to have the previous images because on the previous images, if we can see that the tear was in one particular part, like let's just say it was a posterior horn, purely posterior horn tear. And currently we see abnormalities that are extending all the way into the body. Then we can say, look, posterior horn tear, which was there, you did only a partial posterior meniscectomy. Now we are seeing tear extending all the way into the body and anterior horn. Then I'm going to say, look, this is all new tear. So having old scans is helpful, and knowing what kind of surgery was done is very helpful in making those decisions. And then otherwise flaps and things like that are obviously good things.
Yeah. Tirath is asking, is there a role of a 3D MRI?
So 3D MRI as a concept is essentially the phenomenon where they are now taking images with very thin sections on MRI and giving you the option to reconstruct that data. People who have been reading MRI for a while say invariably there is some loss of resolution, and they are far more comfortable reading these on, getting your regular images rather than getting a 3D cube image. Personally, I don't see any massive change in anything we're doing by using 3D cube. The biggest importance of that would be that if we can get patients scanned faster and still have the same resolution, then that would obviously be fabulous.
Perfect. Thank you. I think, Sajeer, we can continue. Thank you. So, Aditya, if you can unshare this. Yeah, unshare. Yeah.
So Daftary has already described how to come about diagnosing a tear, grading it, and identifying the associated lesions as well. As an orthopedic surgeon, the usual questions when you see an MRI image is, this really a tear? Does it need intervention? And what kind of intervention are you thinking about? Repair, resection? What is the kind of prognosis for this patient? Like, will he be completely relieved or some symptoms persisting? So the most common presentation, bread and butter for an arthroscopic surgeon, would be a patient who is around 40 with no significant trauma, presenting with 1 point area that they show that they have pain, and they have classically clinically medial joint line tenderness. And if you see a tear which is not a clean cut and a ragged like tear which is sometimes complex, and if it is an isolated meniscal lesion, by isolated I mean that it doesn't have any associated ligament injuries, and if you're looking at such a tear with a well-preserved joint space, then you can almost be sure that the arthroscopic picture would be like this, where you have a degenerated, frayed endings, probably tear lines extending in more than one direction. And most often in such kind of tears, we expect a resection rather than repair. Probably because the cause of these tears itself is degenerative in nature. Because we had a patient who was a 37-year-old athlete who had no injury, he had insidious onset medial side knee pain. And he underwent a medial meniscus repair with 2 suture anchors elsewhere, almost 1.5 years back. And then he presented to us recently with the persisting medial side knee pain. He hasn't rejoined his sport, and he has missed almost six months to a year off sport because of the post-op rehabilitation after a repair. At the end of 1.5 years, the meniscus looks even more torn. I can't understand where the repair has happened. And additionally, as a bonus, you have got an anchor in the periphery of the medial meniscus and a large parameniscal cyst formation. So such kind of tears in a 40 around age group with no significant trauma, one should consider resection. Some of the sneaky tears, like Daftary has already described, are these ones. Maybe I call them a single section flap. You may see it only adjacent to the posterior horn area of the medial meniscus, where you can see a flap of the medial meniscus flipped towards the intercondylar notch. And one should carefully observe towards the intercondylar notch, and one can see that these flaps are displaced, and reducing these flaps are essential prior to resection. In very rare cases, you can see that these flaps are displaced posteriorly as well, and one may have to look into the posterior medial corner to resect these. The thumb sign, like Daftary has described, where there's an in-roll flap, where a flap of tissue has gone into the medial recess, like this one, where the coronal and the sagittal section, the MRI looks, the meniscus just looks smaller, and there's no real big tear in it, but there's a huge flap. The patients will have a significant limp and a medial joint line. The flap will be palpable in the medial joint line. And such cases, while you're performing the arthroscopy, be careful to probe the body area and the posterior horn area of the meniscus, because sometimes you will be surprised to see large flaps which are displaced into the recess. And this is a sure shot case for resection, of course. When it comes to degenerative joint disease with a meniscus tear, we are at dilemma, because sometimes we are not sure whether the chondral degeneration is the cause for the pain or the meniscus is the cause for the pain. But when you see such images where a part of the meniscus is missing and the joint space is relatively good, with a sharp medial joint line tenderness and more of mechanical symptoms rather than pain after exertion, we may consider arthroscopy. And if you're really lucky, you may get a flap such as these in a degenerative joint But such patients, we always keep them forewarned that they have a probability that some of their symptoms may persist after surgery because of their chondral degeneration. When it comes to bucket handle tear, which is the most common traumatic type of medial meniscus lesion that most as arthroscopic surgeons observe, Daftary has already described on how to assess the medial meniscus bucket, which is displaced into the notch. And most often, like IPS already described, it's an arthroscopic decision whether to go ahead with a repair or not, because the presence of secondary tears may be not evident on an arthroscopy. But I would suggest you to look at the periphery of the meniscus, whichever is remaining. In this case, one can observe that there is a secondary tear through it. So after this bucket handle tear is resected, one should probe the periphery to check for this second bucket handle tear. Otherwise, you will be ending up with a bucket which is left behind. Daftary also already described that such vertical lines on the meniscus corresponds to any longitudinal tears, and most often such are traumatic tears which are associated with an ACL injury. And if you divide the meniscus like he described, you can find out whether these are peripheral lesions or not. So such peripherally placed vertical lines, one should carefully probe the periphery, because most often you find such peripheral tears which are a sure shot case for a repair. But if you find such similar longitudinal lines in the red-white zone, you can be sure that you will be finding a tear more towards the inner edge. Here you are at it's a surgeon's choice. You may go ahead with a repair or resection based on your choice and the kind of patient you're dealing with. But one additional point, in such cases where you find only an inferior surface longitudinal line, one needs to probe the inferior surface of these meniscus, because most often you don't find a tear on the superior surface. And here you can observe that the tear is only on the inferior surface. And in this particular case, we did an inferior surface only meniscus repair. So when it comes to a sudden onset medial side knee pain in a middle age, or this is not a classic patient, probably in the age group of 50s, this patient was stepping out of the train when he felt a sudden pain on the inner medial side of the knee, and he had limping. And obviously his MRI shows a medial meniscus root tear. But I would suggest you look at the bone edema adjacent to the root in these cases, because this indicates that this root tear is acute in nature. And this is the cause for the present symptoms, because sometimes in degenerative knees, we find root repairs reported, but they're not acute and they're chronic in nature and less likely to be repairable. Most often we are jinxed in surgery when we go ahead for a root repair. We find extensive cartilage degeneration, frayed and degenerative medial meniscus tissue. So we are often wondering whether we can really have some meniscus MRI findings to really predict whether this was repairable in the first place or not. So some of the points that you can take is extrusion, as already discussed, chondral wear of the medial cartilage, and bone edema of the medial tibial plateau or the medial femoral condyle, and intrasubstance degeneration within the meniscus in itself can, these are much more pain generators, like the bone edema and the chondral wear are much more pain generators than just the root tear. So you can have a fair idea on the prognosis of a patient whom you're taking up. On the lateral side, the most common non-traumatic injury would be kind of lesion that you would be dealing with would be a discoid meniscus, but some of the tears are really obvious, but sometimes we are confused because there's no real tear. There is just an intrasubstance signal within the meniscus, and this patient has serious mechanical symptoms on the lateral side. And when we go in for arthroscopy, we find a pristine discoid. But once you start taking bites into this meniscal tissue and start reshaping the meniscus, you observe that the entire central portion of these meniscus are vacuolated and they have a horizontal cleavage within it. And these are kind of like a hidden tear within the meniscal tissue. So one needs to start trimming them to start seeing these tears really. We did a reshaping only in this patient. We didn't go for a repair. The most common lateral side traumatic lesion, like in this badminton player who had a sudden pivoting injury and a lateral side knee pain, she's pointing to the area of pain as well, is a radial tear of the lateral meniscus body. And on an arthroscopy, you can usually find that these tears are in the white zone, and meniscectomy is the ideal option in these cases. But watch out for these tears, radial tears, which extend right up to the periphery. And you may pick up just one coronal image where it is extending right up to the periphery. And you may find, if you are well versed in reading axial images, that you can find the tear is a full thickness body tear of the lateral meniscus, radial tear, which is extending right up to the periphery. In these cases, be ready, because excision wouldn't be an ideal point, ideal surgery in these patients, especially in the young. We would consider something like a repair in these cases, and one must be ready for such cases with a meniscal repair procedure. On having a lateral meniscus cyst, the only additional procedure in addition to the lateral meniscectomy that one needs to perform is a cyst decompression. This is done in various ways by various surgeons. What we prefer is just passing an outside needle and decompressing the cyst fluid into the joint. So the MRI can be helpful because you can find out where exactly the cyst is located. Is it adjacent to the body or the posterior horn or the anterior horn? Because we have cases where we have found a patient with a lateral meniscus tear has a cyst associated to the anterior horn of the lateral meniscus, like in this case. Here, this would be one of the rare cases where we would go ahead with a visualization from the anterior medial portal, because putting a scope through the anterior lateral portal may itself decompress the cyst. So here we went with an AM portal visualization and the introduction of instrument through the anterior lateral portal to approach the cyst and decompress it. After this, we did a lateral meniscectomy from the other portal. So in the meniscus, decision making is always a positive clinical finding, and correlating the clinical finding with an MRI with a good X-ray. And the decision for repair versus resection, MRI has a very high predictability, and you can keep the patient forewarned and ready for a longer rehab. Coming to the cysts which are associated with these tears, one can locate them and see the size of the cyst as well on the MR to see the amount of fluid and the area that you want to decompress these cysts. Regarding root tears, there is a big role for the MRI in addition to the standing X-ray and the alignment views for tissue repairability, tissue quality, and chondral status. Now, I think there's one topic only which Daftary needs to cover is the ACL.
Okay, there are two questions, I think, both to you and Daftary. One is Dr. Siddiqui has asked, the proton density imaging is same as T1, or is it anything different?
It's
So
different.
maybe,
It's completely different. But
Yeah.
essentially, so the old school was that we used to do T1 weighted images because
Yeah.
the original studies were done using T1 weighted images. But today we use fast spin echo proton density images. Essentially, we can get much more information, and they are as diagnostic. So yes, I mean, we don't need T1 weighted images. The only time we really need them is when we're looking at tumors and infection.
Perfect. Sajeer, you showed about the root tear where there was an edema also. So that indicates an acute tear, isn't it?
That's what we have seen, that most of the acute root tears do have an associated edema at the root attachment towards the posterior medial portion of the tibial plateau. And we have consistently found this in most of the tears. And if you start observing the longitudinal tears that are associated with ACL injury as well, you may observe a focal bone edema adjacent to these tears, indicating the acuteness of these tears.
So if the cartilage is not bad, you would actually go ahead and repair these things.
There are multiple factors that we consider. If we can really reduce this extrusion, if the chondral status is good, if the X-rays are well preserved, if the patient has a neutral alignment, then we would consider going in for a root repair. But ultimately, when we introduce the scope, we may find chondral degeneration, which we didn't see on the MRI, and we are amused. So we always plan in such a way as SOS. If in case we find a good cartilage, then only we repair the root.
But your technique of your cyst decompression from outside in with the needle was amazing. That's really impressive. Thank you very much for that. I think I've already talked to Aditya on chat box. Probably if you guys are free sometime later next week, we can fix up a time for ligaments. I think a lot of questions would be coming in ligaments, and we won't be able to justify with a short span. We already spent nearly an hour and a half now talking about cartilage and edema. So maybe we can end it today here, and if Sandeep can coordinate with Aditya, if it is comfortable, we fix up a time where we can talk about ligaments at length, because I think ACL is something which is very common in our practice. There will be huge amount of questions regarding partial ACL tears, acute ACL injuries, ACL repairs, and also double bundle ACL reconstruction, stuff like that. So ACL, PCL, MCL, LCL, probably we can cover anytime later, Aditya, and I think Sandeep can talk to you guys. So no more questions. I think I must thank
Tirth
you
has
guys.
question, sir.
Tirth has a question. Sorry, Tirth. I mean, I'm just, please.
Good evening, sir. I want to know whether there is any radiological scoring system which helps us to decide between repair versus resection for meniscus.
So specifically, I mean, if you think I think you have to think about what is it exactly that makes you decide that you're going to repair a meniscus or not. So your chances are better if something is obviously more in the red zone versus in the pink zone or in the white zone. So as far as when we report our tears, we say there's a tear. If it's a longitudinal tear, we say it looks like primarily in the red zone or in the white zone. The short answer is there is no specific scoring system. Which is what most orthopedic surgeons would like. Number 6 means operate. Number 2 means don't operate. But unfortunately, no, that's not the case. So then we just give you sort of what are the parameters that would help you make decisions. So if it's a root tear with extrusion, without extrusion, how much extrusion? It looks acute, it looks non-acute, bony avulsion, not root adjacent or just in the posterior horn. And if it's in the longitudinal, is it longitudinal? Is it sort of pink zone, red zone, white zone? And then that, because most of the time anyways, the decision ends up being taken on table. This is just to give you a pre-operative probability of your likelihood of doing it.
Yeah, thank you.
Any more questions?
I think IPS, there is no question anymore.
Yeah, Samanta, if you can just conclude it, and then we can thank Aditya and Sajeer both.
Yeah, I thank you, Dr. Aditya and Dr. Sajeer, because this was we are continually doing this educational program through our IAS web platform. And we are really grateful that you people have agreed to come and join. It was really excellent. Even we could gather some information even after seeing MRI for so many years. So I think this was a joy to watch both of you. So even IPS, Bhupesh, we are all doing arthroscopy since long, but still we learned many things from you people. Thank you all. And I special thanks to Sandeep, because he is organizing all this. I think Sandeep, you please coordinate with Dr. Aditya and Dr. Sajeer to go ahead with the next program with something with the ligaments and the collateral, so that we can again learn something new. Thank you.
Aditya, Sanjeev, thank you very much.
Thanks very much for having me here.
It was absolutely practical. It was absolutely amazing, because this was one which we wanted to look at it. Thank you very much.
Great. Thank you so much.
Perfect. Friends, we are talking to Aditya and Sajeer if we can do another session next week. They will look at their calendar, and then we'll finalize the brochure accordingly and let you know. Coming this week on Friday, on 21st of August at 6 p.m., we have Dr. Kibler. And I think nobody who is into shoulder arthroscopy and shoulder sports medicine does not know the name of Dr. Ben Kibler. Dr. William Ben Kibler is from Kentucky, US. He's running Lexington Clinic. He's an amazing guy, and his work into shoulder dyskinesia is, I think it's a treatise to hear the master himself. We are lucky that he has agreed to be coming on the IAS platform. He's going to talk about scapular dyskinesis. This is something which probably even experienced arthroscopy and sports medicine surgeons and shoulder surgeons need to learn from the master himself. So Dr. Kibler would be there at 6 p.m. on this Friday on 21st August. Do join in on our IAS YouTube channel and also on Zoom Live. Thank you very much, friends. And thank you very much, Sajeer and Aditya, for helping us to understand MRI.